So hi everyone, thanks for joining. So today we're going to be talking a bit about respiratory physiology. I'm going to stick quite closely to the spec, the left-hand side, just for this talk, because there's so much to cover in this topic, and if I went on to the right-hand side, we wouldn't get anything done in an hour. But hopefully these will be a good start for your revision. So yeah, let's get started. So the key values for respiratory physiology, the things to know for those MCQs. So we've got the resting oxygen consumption, 250, the resting carbon dioxide production, the alveolar and arterial partial pressure of oxygen, and that of carbon dioxide, and also the pulmonary blood pressure. So take a quick look at these, try and put them to memory as quickly as you can. And we'll come back to each of them, but just try and get those in your head, try and think of a way that you can remember them. I find these two are quite good to remember relative to each other. Okay, let's move on. So we're going to start off with an overview of pulmonary function. So this is the relevant bit in the spec. So in principle, the lungs are basically the site of gas exchange, as you all know. So just a few definitions. The ventilation is a process by which gases are exchanged between the atmosphere and the blood vessels of the alveoli. So the oxygen is going into the blood and the CO2 is coming out. So the key values to know here are the oxygen consumption and the CO2 production. So if you're writing an introduction about the lungs, these are the basics that you just need to be able to regurgitate, put down, and that ventilation definition is a really good one to know. So regions of the lungs, also a very important concept to be aware of. So we've got number one, the anatomical or respiratory dead space. And then the second section is the respiratory zone. So in the respiratory dead space, it's the trachea here to the conducting bronchioles here. So there's no gas exchange here, and it's only the bulk flow of these gases going through. It's about 150 mils. Whereas the respiratory zone, you've got the respiratory bronchioles, the alveolar ducts, and the alveolar sacs. And this is where gas exchange occurs, and lots of diffusion. So the diffusion of oxygen going in and the CO2 out. And its volume is much bigger. It's 3 litres. So that just shows how important these alveolar sac structures are. So the partial pressures in the lungs. First, we need to know what partial pressure actually means. So it's basically the pressure exerted by a gas if you imagine that it was the only one of the original mixture at the same volume and temperature as your mixture of gases, so your nitrogen, your CO2, all of those. So the units are kilopascals or the millimeters of mercury. And they really have quite similar partial pressures in the alveoli compared to the arteries. Because the gas exchange is constantly occurring. So they equilibrate, basically. So the key values here, just another revision. So we've got 90 millimeters of mercury for the oxygen, and you need to know that it's also 12 kilopascals, and then CO2 is 40. So these are numbers, unfortunately, you're just going to have to learn. Just make some flashcards, go over them a few times in a week, and they'll just stick eventually. Just one of those things. Right, so the next section that you need to know is about the respiratory mechanics, the mechanics of the lungs. And this is divided into 2 sections, the first of which is statics. So this is talking about the tidal volume and all these different measurements of lung volumes. So this is the diagram that I found it was really, really useful just to learn, because it saves you so much time in an essay if you can just bash out this diagram with a few of these labels, rather than having to describe it all in words, which could take up about 2 pages if you were not being careful. So these lung volumes are measured using a spirometer, and the changes are equal and opposite. So if you breathe out, the spirometer goes up, breathe in, it goes down. So the tidal volume, TV, is the normal change in the pulmonary volume. So it's just this little wiggle here, going in and out, and it's kind of passive inspiration and expiration. And it's typically about half a litre, 500 mils. The next ones we need to know are the vital capacity, which is that maximum change that the lungs undergo. So it's the volume exhaled between maximal inspiration and forced expiration. So it's this big jump here. And it's about 5 litres, so much bigger than our normal tidal volume. And how you would work it out, this is a really good thing to know, because in MCQs they can often test you on this, give you a few of these values and make you work out any of the others. So it's equal to the inspirational reserve volume here, so above your tidal volume, and the expirational reserve volume, so just below your tidal volume. The next one is the functional residual capacity, and so this can't be measured directly because it's the volume of air in the lungs following a passive expiration, and some of that can't be measured. So we have to measure it indirectly by helium dilution, which I'll talk a bit about because that's something you do need to know about. Helium is insoluble in the blood, so that's why we can use it to work out this volume. So it's not lost in this pulmonary circulation. So the subject will breathe in from a container that contains helium, and we'll use this equation to work out that residual volume. So here C1 just means the initial concentration, C2 is the final concentration, V1 is the volume in the spirometer, and V2 is the volume in the lungs. So you can see how we can rearrange this to get this final volume in the lungs. So yeah, as I said, we can calculate any of these values indirectly. So another important concept to make sure you really understand is this concept of intrapleural pressure. So this is the pressure between the visceral layer, this inner green layer, and the parietal, which is this outer layer that lines the kind of ribs. And so the important thing just to bear in mind is that the lungs inherently want to collapse. They want to kind of fall in on themselves. And if it weren't for this intrapleural pressure, they would collapse. But because we've got this negative pressure in between these layers, it kind of holds the lungs out, it holds them expanded. And the mean value is -6 H2O, so that's a really, really important value to know. Although do bear in mind it does vary. It's higher, more negative, sorry, at the apices, so the top of the lungs, and it's -2 at the base. So that basically means that the apices are going to be much more expanded at rest than the bases. The bases will be more collapsed because we've got a less negative intrapleural pressure. So that will just take a little bit of kind of saying it to yourself, getting your head around it. Right, so talking a little about a clinical case that we can see in the wards. So we've got pneumothorax. So we'll talk a bit about why this happens and why it's a problem. So during inspiration, the intrathoracic volume, it increases. You can see the arrows kind of pointing out here. And this creates a more negative intrapleural pressure. So the lungs are going to be stretched out more. Whereas during expiration, this volume, decreases, and it creates a more positive pressure because the lungs will collapse. So pneumothorax, which basically means air in the lungs, pneumo, or air in the chest, pneumo, air, thorax, chest. And this happens if the lung or the chest wall is damaged, and this air enters the intrapleural space, and it causes this force that's holding those lungs out to be lost, and the lung can completely collapse. And that can be really life-threatening if you don't pick up on it quickly and get all that gas out. So going on to our Socrative, could everyone please answer the first question? I'll give you a couple of seconds. What is the average resting rate of oxygen consumption? A couple more seconds, just have a guess if you're not sure. It's all anonymous, so don't worry about me knowing your names. Right, let's have a look. Yeah, 250, you all got that right, well done. Right, next question. What is the average resting rate of carbon dioxide production? Let's have a look. Brilliant, so it's 200 mils per minute. So oxygen is 250, carbon dioxide is 200. Right, next question. what is the respiratory dead space? What structures, I should have said. So have a look. Brilliant. So trachea to conducting bronchioles. Very good. And next question. So what is the partial pressure of oxygen in the alveoli? A little bit trickier. Brilliant. Great. So most of you got that one. It's 90 millimeters of mercury. So this is just one of those things, if you either know it or you don't, and unfortunately it's just one of those rote learning things. Next question. What is the partial pressure of carbon dioxide in the alveolar arteries? So oxygen was 90. What was carbon dioxide? Let's have a look. 5.3 kilopascals. Well done. So it's a bit annoying you have to know both the millimeters of mercury and the kilopascals, but unfortunately they could test you on either of them. So good to bear in mind both. Brilliant. Moving on. How is the vital capacity calculated? So the vital capacity was that larger volume. Yeah. Keep them coming in. Brilliant. Fantastic. So it's the inspiratory reserve, the tidal volume, and the expiratory reserve. So be really careful because it's easy to misunderstand which what they actually mean. IRV can sometimes look very like IC or whatever when you're reading it in a rush. But really good. So next question, just check. Yeah. Which of the following statements is true? So the tidal volume is approximately 800 mils and vital capacity is 5 litres. Tidal volume 800 and vital capacity 8 litres. Tidal volume 500 mils, vital capacity 5 litres. Tidal volume 500 mils and vital capacity 8 litres. What do we think? Have a guess if you're not sure. Right, let's have a look at the results. Brilliant. So again, most of you, so tidal volume is approximately 500 millilitres and vital capacity is 5 litres. So I find that quite easy to remember because they're both 5 and one's small and one's bigger. Great. And our last question for this section. The intrapleural pressure is typically plus 10 centimetres H2O. True or false? Easy peasy. Brilliant. It's false. And can anyone tell me in the chat, or Lisa, because I can't see, what's the real value? I can't see the chat, so I can't tell, but so it's -6 H2O, okay? Or a range if you're looking at the base and the APCs. Brilliant. So let's move on to our next bit. So we're going to be talking about compliance now. And this basically talks about how stretchy the lungs are. So how easily a change in volume, as we can see on the y-axis here, can be induced by a change in pressure on the x-axis. So the ideal level is actually in the middle of the lung. And the alveoli here are inflated enough, but they're not overinflated. It's worth noting that the base of the lung is actually more compliant than the apex, because as we talked about before, we had that less negative intrapleural pressure. So it's less expanded initially, less inflated. So it does undergo a larger change in volume. So that's a good thing to talk about if you get to that in an essay. So yes, this is the equation, change in volume over a change in pressure. So it's demonstrated quite nicely by this graph. So surface tension is really important for compliance. It's basically the force exerted by a fluid in the alveoli, which promotes alveolar collapse. So rather than going like this, the alveoli will look a bit more like this if you've got a high surface tension. And I think of that just being like, if something's pulling in, which is the pressure, what I see the surface tension pressure being, it's pulling it in, it's collapsing it. So it's basically caused by these cohesive properties of water, and it's useful for expiration, sorry, as opposed to inspiration. So it's reduced by surfactant. So this surfactant ensures that we have our puffed up alveoli like this rather than our collapsed alveoli. And this surfactant is secreted by type 2 alveolar cells, and is made up of phospholipids and proteins. And this prevents complete collapse at the end of expiration. So although this might be useful for pushing all the air out, it's actually very difficult to re-expand these alveoli once they're completely collapsed. So we need the surfactant to ensure that we can get to this state again. Because if we're in this state the whole time, it requires a lot of energy to re-expand. So a lack of surfactant can cause respiratory distress syndrome. So this happens a lot in little preterm babies, and the surfactant production can often be insufficient in these little ones. And that means taking their first breath can be a lot harder, and they need a lot of medical attention in their early years. So moving on now to the dynamics, which is our second section of respiratory mechanics. We've got two types of flow here, as you can see on the right. So flow and resistance are very interlinked. Airways resistance determines the rate of this flow in the face of an applied pressure. So that just means kind of how much pressure there is in your airway. So that's in another equation that is good to know. Sometimes for essays, but sometimes you might need it for MCQs. They might ask you to calculate one of them. So yeah, our two types of flow are laminar flow and turbulent flow. The laminar flow is when the Reynolds number is less than 2000. And I won't go into what that means exactly today, but it might be something worth looking up if you do want to mention it in an essay plan. So yeah, we've got this parabolic flow profile. So it's just like a parabola. And the flow is proportional to the pressure gradient. So those are the key things for laminar flow. Turbulent flow is when this number is greater than 2000. And it has a flatter flow profile and a more disordered motion, as shown by these little arrows. And it means that the flow will be proportional to the square root of the pressure gradient. And this turbulence is actually what causes this kind of wheeze that you might hear in some patients' lungs when you get onto the wards. It's responsible for the wheeze that you can hear without a stethoscope in people with asthma. Right, so looking at the resistance in the airways, it's really dependent on the radius of the airways themselves. So this is the important law to know, Poussey's law. And it describes the relationship between resistance, length, radius, and viscosity of the gas. So there it is. And it basically shows you that with a doubling of the radius, the resistance is going to decrease by 16 times because of this to the power 4 for a given pressure. So an important thing to note is that the larger airways, such as the trachea, are actually going to have a much higher resistance than the tiny ones, the terminal bronchioles. You can see this curve goes massively up and down. And this little peak is caused by the carina, which is the splitting where the trachea splits to form the two main bronchi. And this carina, it causes a massive increase in resistance as well. So this is a really good shape just to be aware of, because it will really help with your explanations. So thinking about some respiratory diseases now and how they relate to resistance. So in asthma, the bronchiolar and bronchial smooth muscle is a lot more contracted. And this will reduce this diameter of our airway quite significantly. And that's therefore going to increase the resistance and decrease the flow. And if you want to explain that really nicely, you can refer to your Poussey's law. So yeah, this is going to reduce the overall ventilation and and impair gas exchange. And that's kind of just intuitive because someone with asthma, they just find breathing a little bit more difficult. So this is a nice simple explanation for a relatively commonplace disease. So in COPD, which is a very common respiratory disease, particularly in smokers, there's breakdown of the alveolar sacs. And this really increases compliance. And thinking back to our slides before, it makes expiration much more difficult. And air can get trapped in these tiny little sacs because they kind of burst and merge into each other, and it's not as efficient. You can't expel the air out as easily. So this is also going to really impair your ventilation and your gas exchange. So for these diseases, we need to know how to diagnose them, and there's two very simple methods by which we can do this. So we've got number one, which is peak expiratory flow, and we've got number two, which is forced expiratory volume in 1 second, which is the value you can see in this graph here. So the peak expiratory flow is a very simple test, and it just measures the patient's maximum speed of expiration. So you breathe into this tube, and you basically just ask the patient to breathe out as quickly as they can, and then you measure how much they manage to exhale. So it's measured using a peak flow meter, and the lower readings indicate obstructive airways disease. So these are ones such as asthma and COPD, the ones that kind of block up your airways. So this FEV1, it's measured using a spirometer, as we saw with our lung change volume graph. And it basically measures the amount of air a patient can force out of their lungs in only 1 second. So the lower readings will indicate obstructive or restrictive. So we've got obstructive here, which are our asthma, our COPD. We've got our restrictive here, which are more to do with the kind of connective tissue of the lungs. So it could be lung fibrosis, that sort of thing. Right, so moving on, we've got to talk about diffusion of respiratory gases. So going back to our diagram from the start, CO2 goes into the blood, oxygen goes into the blood, and CO2 goes out. So the diffusing capacity of the lungs is really about the rate at which this process can happen across this barrier between the alveolus and the blood capillary. Pretty basic stuff. We're going back to our fixed law of diffusion, which I'm sure you've all heard of. So it's the flux is equal to dAcx, and that all seems a bit like nonsense until you kind of break it down. So we've got D as our diffusion coefficient, A is our surface area, C is our change in concentration gradient, and delta X is our diffusion distance. So they'll probably give you this diffusion coefficient if they're asking you to calculate this flux, and the rest they'll give you all the values you need if they do ask you to calculate something like this. It's just worth learning this equation in case they don't give that to you. Right, so going into this in more detail, this equation tells us that the rate of diffusion is proportional to the surface area of the barrier, and the partial pressure difference and the solubility of gas, and it's inversely proportional to the thickness of the barrier. This is representative of that X there. So looking at the lungs, why are they designed as they are? And the answer is just to optimize this equation, basically. So we've got a huge surface area, 80 to 140 meters squared, massive. And we've also got these really steep concentration gradients because we've got hemoglobin, which we'll talk about more in a sec. And we've got very constant blood flow going through the lungs. And we've also got ventilation, which is changing the gas concentration all the time. So, and also, yeah, our blood gas barrier is only 0.3 micrometers thick. So all of these things mean that this equation here is optimized. So let's have a look at some pathologies that affect this diffusion rate. So again, going back to COPD, COPD causes emphysema, which is a complicated word for just the breakdown of this barrier. So we're going to reduce our surface area. And then pulmonary edema just means fluid in the lungs, and that's going to add a barrier to our blood gas barrier. It's going to add another layer between the blood and our alveolus. So we're going to have a bigger diffusion distance. And then pulmonary fibrosis, I mentioned before, it's the scarring of the lungs. It's happened to a lot of patients with COVID. They have all this residual scarring in their lungs, and they have a lot of complications from this. So it decreases the effective surface area, and will also reduce the compliance of the lungs. So you're going to have less surface area, you're going to have less of a steep concentration gradient. So our diffusion is going to be a lot lower, and your oxygenation of the blood is therefore going to be a lot less. So now looking at some oxygen transport. So this was something that I found a little bit tricky at first, but I think it's just best to simplify it down to the basics. So let's have a look. It takes 3/4 of a second for blood to travel along the length of an alveolar capillary. And oxygen has to equilibrate with the blood in this time. So we've got two methods of doing this. We've got oxygen dissolving in the plasma, and we've also got its association with hemoglobin. So these are both very important. Hemoglobin is potentially the most important because oxygen isn't actually that soluble in the blood, as opposed to carbon dioxide, which is very, very soluble. So hemoglobin is a tetramer, and it's got 2 alpha and 2 beta subunits. And each subunit has a heme group, which contains this central iron ion that reversibly binds oxygen, and that's known as oxygenation. So the reversible binding means that the oxygen concentration gradient can be maintained because it kind of hides the oxygen away from the body, so it's no longer involved in that concentration gradient. So that's really useful for gas exchange. So yeah, without hemoglobin, the plasma isn't really going to do enough. So with the hemoglobin, it's worth mentioning this, the dissolving in the plasma, but it's not. You need to make sure that you show that you know that this second option is the most important. So looking at this lovely curve, this lovely sigmoid curve. So basically it shows that when there's a high surrounding PO2, hemoglobin is going to gain oxygen and form oxygenated hemoglobin. So going up the curve, it's gaining oxygen. Yeah. When there's a low surrounding PO2, the hemoglobin is going to lose oxygen and form deoxygenated HB. So this is showing your saturation, oxygenation versus deoxygenation, and this is showing your external PO2. So going up, we gain, and going down, we lose oxygen. So the oxygen binding is cooperative, which is what makes this curve a sigmoid. The binding of the first one means that the rest bind more easily until the last, and the last one is going to bind less easily, but just because there's fewer binding sites. It's not to do with any protein conformational change or anything like that. And the same applies for the losing of the oxygen. The first one is going to be lost most readily, and then these are going to be lost pretty quickly. So optimization of this curve is another thing that happens in the lungs. So, and in the tissues, sorry. So it's determined by 4 factors. The first 2 we're going to talk about are the CO2 and the hydrogen ions. So the combined effect of these 2 is known as the Bohr shift. And this is really important to know, Bohr effect, sorry. It's important to know it's the combined CO2 and hydrogen ions. So in respiring tissues, we've got an increased carbon dioxide level, and we've also got an increased ion, and that's just because of respiration. And yeah, so going on, this causes the shift, the rightward shift in this curve. And that basically means there'll be an easier dissociation of oxygen for a given PO2. And looking at this graph, we can understand that by looking at our 50% hemoglobin goes here, and looking down, we've got 30% PO2. But then if we look at our rightward shift, when there's more CO2 and more hydrogen, we've got a lower oxygenation. We've got 40%. So it just means that the hemoglobin will dissociate from this oxygen more readily for a given PO2. So it just takes a little bit of sitting down, staring at the graph, just making sure you really understand that. So this basically means that you'll have a faster delivery of oxygen to the respiring tissues, because if you've got a higher surrounding PeCO2 and H+ in these tissues, and you've got an easier dissociation of oxygen, more is going to fall off in those regions. Right, so now looking at the temperature and this molecule called 2,3-DPG. So we know respiring tissues like muscles, you're going to have a higher temperature because respiration is exothermic. Then we've got increased 2,3-DPG, which is an end product of erythrocyte metabolism. So that's also going to be in places where more energy is being used up, and therefore there's more anaerobic respiration. So again, these are kind of representative of places where there's more oxygen required. This is also going to cause a rightward shift. Again, it will mean that there's an easier dissociation, more oxygen is going to fall off that hemoglobin because we've got a slightly further shift to this way. And that will mean that we have a faster delivery of oxygen to respiring body tissues. So I'm not going to bore you by going through the other way, but leftward shift is basically a decrease in all of those things. So you're going to want to hold on to your oxygen. The hemoglobin is going to want to hold on to its oxygen a bit more in places where there's less of these processes required, and therefore less oxygen required. So let's have a look at the Socrative. I'll stop talking now for a bit. So our next question. Surfactant is produced by type 2 alveolar cells and reduces what? Brilliant. Just have a guess if you're not sure. You're doing really well, guys. Okay, let's have a look. Brilliant. So all of you got that right. Surface tension. So surfactant reduces surface tension, which then in turn increases lung compliance. That's important to know. Right, let's have a look at the next one. Which of the following statements correctly describes the Bohr effect? So I can go through them if you like. So the oxygen binding affinity of hemoglobin is increased by low pH, reduced by low pH, increased by high pH, or reduced by high pH. Fabulous. Brilliant. So most of you got that right. It's reduced by low pH. So a low pH means that more oxygen is going to fall off our hemoglobin because that's going to be a place where more respiration is happening, more oxygen is required. Brilliant. Well done. So, yeah, final question for this section. An increase in 2,3-DPG in erythrocytes. What effect does that have on oxygen unloading in tissues? It's a bit of a wordy one. I'll give you a bit more time to read through these answers. Brilliant, let's have a look. Great, so again, most of you got that right. It enhances the oxygen unloading in tissues by shifting the curve to the right to higher PaCO2 levels. Fantastic. Right, let's continue. So only a couple more sections to go now. So we're talking about carbon dioxide transport. So this is a really big topic that I'm going to try and summarize down. But they really do like to ask essays on this, so it's worth learning well. So yeah, as we know, carbon dioxide is produced at a basal rate of 200 mils per minute. And it's an acid. So we need to make sure it's really carefully controlled because we have to maintain our pH between certain limits. So we've got 7.35 to 4.5, and it's a really, really tight range. And if it goes out of that range, lots of proteins, lots of functions won't work anymore. So we need to really control the amount of carbon dioxide that's floating around in our blood. So it's transported in 3 ways. The most important is these bicarbonate ions, which is 75%. But we've also got dissolved CO2 and carbamino CO2. So we'll talk about those a bit. So as I've mentioned briefly before, it is a lot more soluble than oxygen, 20 times more specifically. So it really does equilibrate faster, and it doesn't require a transport protein such as hemoglobin, because more can be dissolved. So that's a good thing to know. So looking at the bicarbonate ions, the buffering of these occurs inside the red blood cells, as you can see here. So we've got these reversible equations, which I'm sure you know back to front. We've got CO2 and water going to these carbonic acid, and then we've got the H+ ion and the bicarbonate ion. So this first step, CO2 to NH2O to carbonic acid, sorry, is really sped up by this enzyme called carbonic anhydrase, which is found in these erythrocytes. So that's really why most of the buffering happens here. So the H+ produced by this equation is actually buffered by hemoglobin, as you can see here, HbH. And they basically just bind to the nitrogen groups in this protein. And if you remember your biochemistry, it's because it attaches to the lone pairs of the nitrogen ion. And that means that they lose their effect entirely on pH, which is great news for our tight range of pH in our blood. Great, so this is just a diagram I drew. I think it's a copy of a textbook one. So in the tissues, the CO2 diffuses into erythrocytes. So here we're looking at these black arrows. So we've got our CO2 diffusing in. And this is going to initiate these reversible equations. So this top line here, and it's going to increase the amount of bicarbonate. And this bicarbonate is going to diffuse out of erythrocytes. And that's really aided by this protein here, which is the chloride shift. So these chloride ions are transported in so that we don't get this imbalance of charge on either side of the erythrocyte membrane. And this is going to push the equilibrium towards the production of these bicarbonate and H+ ions because they're being continually removed. So we're going to keep on picking up that CO2 from the respiring tissues. So that's really great news because we want the CO2 to be transported in the erythrocytes to eventually get to the lungs and be excreted. So at the lungs, we're looking at this pink box now, these pink arrows, and the oxygen is going to diffuse into the erythrocytes from our inspired air. The hemoglobin is going to be more frequently bound to oxygen. So we're going to go kind of like this. So it's going to be a less good buffer for this H+. And so as this H+ ion increases, it means that the equilibrium here is going to shift more towards the CO2. And that means we're going to get more HCO3 ions transported in to help us with this equation here. And we're going to get more CO2 being transported out and into our alveoli to be expired in our expired air. Does that kind of make sense? This diagram is really worth just having a look at. It might be one that's a bit too complicated to draw in exams, but worth kind of knowing the principles of it. Okay, so now having a look at VQ matching, something I always found a bit tricky. So I'll try and talk through it slowly. I think we're doing okay for time. So pulmonary perfusion just refers to the blood flow. So here, this red box. And it is talking about the delivery of blood to the capillary beds of the lungs. So we know our pulmonary circulation is low pressure, 20/10. And so it's a very big paragraph, but it basically is saying that we need to keep our arterial oxygen and our CO2 arterial concentrations constant, so at those levels that we learned earlier. So the really important thing to know, so we've got the base here and the apex here. This graph is really, really worth learning, and I'll talk a bit about it in a minute. But so we've got a higher blood flow at the bottom of our lungs than at the top. And this is just because of gravity. So basically more blood is falling down here to the bottom of the lungs. So thinking about VQ matching, so this is just the matching of the ventilation with the blood. And it's really important for healthy gas exchange in the lungs. So talking about ventilation now, it's also higher at the base than at the apex. And this is also due to the effect of gravity, but obviously, as we're talking about air rather than blood, it's going to be slightly less affected by gravity. So that's how I would remember how to draw this graph, because we've got the steeper line, which is the blood, the heavy blood, which is grounded towards the bottom, and we've got this air, which is kind of affected by gravity, but not so much. So they're both going higher to lower, but the air is just going slightly less high to less low, and that's why they cross there. So yeah, this basically means that the VQ ratio is going to be bigger at the apex of the lung, where the ventilation is highest, just because we've got V over Q, ventilation over blood flow. It's going to be highest here, as we can see by this line, it goes up, and lowest at the base, where we've got the other way around. So this basically means that the top of the lung is going to be over-ventilated, as opposed to the bottom of the lung, which is going to be relatively under-ventilated. So that's a really good thing just to be able to talk about. So mismatching can also occur. Sometimes that's normal, but it can be significant, and if it's significant, it can impair our gas exchange. So a lowered ratio can happen in asthma or acute pulmonary edema. So in both of these conditions, we're going to have less air getting in for the amount of blood that is going around your lungs. So decreased ventilation for a given perfusion. On the other hand, we can also have an elevated VQ, which can occur from a pulmonary embolism, which is just a big blood clot in your lungs. And this decreases the amount of blood that's getting to your lungs for the amount of air that's going in and out. So you're going to have reduced efficiency of gas exchange. So pulmonary shunting is an extreme cause of this. So basically it's where the VQ ratio is 0, because we've got no blood going through. And this happens in hypoxic regions, and these arteries will vasoconstrict. They'll get very small, very thin, stopping the blood going through. So it lowers the perfusion to match the lower ventilation. And this is good for the lungs, really, because it means that blood will be sent towards places that are being ventilated. So you'll help the VQ matching in other regions. But this can happen to a significant degree at altitude, which can be devastating because it just completely shuts down your lungs. And it can resolve over time, but it can cause problems with your heart, particularly this thing called cor pulmonale, which is where your right heart muscle gets really big. It can lead to complications down the line. Brilliant. So let's go on to operative once more. So carbon dioxide is transported from tissues to the lungs in the blood, mainly as brilliant bicarbonate ions, because it's very soluble in the blood. Okay, blood flow in the lungs in an upright individual is it greater at the lung apex, greater at the lung base, or the same in the lung apex and base? This is blood flow. Let's have a look. Brilliant, greater at the lung base because blood is very heavy. Fantastic. So the ventilation perfusion ratio is greater at the lung apex, greater at the base, or the same at the lung apex and base. Let's have a look. So it's greater at the apex. I know what some of you are saying, regulated to be the same, but as we were talking about with this graph, let's go back a bit. So we've got this line, so this is our VQ ratio. So it's much, much greater at the apex. Yeah, because we've got V over Q. So we've got ventilation here and Q there. So it means our ratio is going to be really, really high at the apex. Okay, if you have any questions about that, let me know. Okay, as a result, the alveolar PO2 is so the answer is greater at the lung apex. We can discuss that in more detail if you want over email. Just want to get through the slides today, but do let me know if you want to have a Zoom chat or something. I've got loads of time. So, okay, a decrease in the average VQ ratio for the lungs could be caused by decreased cardiac output, bronchial constriction, decreased pulmonary arterial pressure, or pulmonary arteriolar vasoconstriction. What do you think? So we're decreasing the VQ. So just think about what V over Q means. Okay, let's have a look. Bronchial constriction, yeah, because we're decreasing our ventilation there. Okay, right. So let's have a look at our last few slides. Not long to go now. We're just going to have a brief look at the control of breathing. So here's a nice picture here of the brain. You'll learn more about this in second year, but for this topic, you only need to know a few things. So breathing isn't really under conscious control entirely. So when you start thinking about your breathing, you can control it. But most of the time you're not thinking about it and it's just happening and your blood has got the right amount of oxygen, right amount of CO2, and it's all fine and dandy. So the rhythm is generated within the brainstem, so in the medulla oblongata cells, this structure here. It's kind of right here, this orange one. So the mechanism is not really understood, but it involves this complex here called the Pre-Botzinger complex, and also these other centers. I don't think you need to know too much detail about them, but if you want to show off in an essay, I guess you could list them if you'd like. So these areas are subject to modulation by the pons, the cortex, and also the chemoreceptor reflexes, which we'll talk about a little bit now. So chemoreceptor reflexes are controlled by the central receptors and also the peripheral receptors, which we'll talk about in a sec. So these central chemoreceptors are here and here. So they're 70% of the way between the blood and the CSF, closer to the CSF, as you can see here. So they respond quite slowly to the changes in pH, and they respond specifically to the changes in the CO2 in the plasma. And this occurs via changes in the pH. So we use these reversible equations again. So the CO2 diffuses across because it's a soluble gas, makes carbonic acid, which makes bicarbonate and protons. And this is what the central chemoreceptors detect eventually, but it stems from this CO2 in the blood. So they initiate a really powerful increase in ventilation. in response to hypercapnia. So this is kind of the thing you need to lodge in your memory. So the bottom line is basically they're slow to respond, but they induce really large changes. And note that it's the response to hypercapnia, which means high CO2. Right. Peripheral chemoreceptors. They're in the aortic bodies and the carotid bodies. So the carotid bodies are here, between the carotids, and the aortic bodies are here on the aortic arch. So they respond quickly to changes in plasma oxygen. It's important to note that. And they signal via the vagus and the glossopharyngeal nerves, which you'll also learn a little bit more about in second year in your neuro side of things. But for this module, you just need to know that the glossopharyngeal goes to the carotids, vagus goes to the aortic bodies. So these receptors, this is a lot of detail, but they're formed of type 1 and type 2 cells. Type 2 cells are detecting the changes, so they're detecting the change in oxygen, and they're releasing the neurotransmitters which stimulate the type 1 cells. And the neurotransmitters they release are acetylcholine, dopamine, and ATP. So their changes they induce aren't actually that great compared to the other receptors. So the bottom line is they're fast to respond, but they only induce small changes. And the other thing to note is that it's a response to oxygen as opposed to the level of CO2. Brilliant. So our last section, let's just bash through the last Socrative questions. So the central chemoreceptors in the brain are stimulated by what? A fall in arterial potassium, local oxygen, arterial CO2, mean arterial pressure, or a rise in local pH. So have a look. Great, a rise in arterial PCO2. Brilliant. And then a rise of alveolar PCO2 by 10 millimeters of mercury will do what? Have no effect on ventilation, induce hyperventilation, induce hypoventilation, or induce systemic vasoconstriction. Let's have a look. Brilliant. So it induces hyperventilation. So if you have a higher amount of CO2 in your blood, you're just going to want to blow it all off, get rid of it by ventilating more quickly. Brilliant. So that's the end.